So, Hector, I'm very pleased to see you here after the fact, after the EuroPCR, but there was no time to do it during the PCR, so we do it now. So let me start first with the introduction. Many know you, of course, so you don't need an introduction, but you are director at the core lab at MedStar University Medical Center and also professor at Georgetown University. And of course, have been in the field of coronary physiology for a very long time and familiar with the QFR and also with other systems. During the PCR, you were the chairman of the MEDIS Biotronic Symposium. And also you had, of course, we had, I think, great presentation at the meeting. And you also summarized it at the end very nicely. So would you mind for the audience who will be listening to this recording to summarize your summary of what you said there in Paris?
Yeah, thanks, Hans, for having me. And it's great to be able to actually tell the colleagues. So at the symposium, we have a few presentations on QFR and on FreeSolve. And what came out of the session was a kind of new workflow for integrating QFR and new technologies like FreeSolve. And we learned from the speakers that, of course, QFR is very well known for its diagnostic capabilities. So there is no doubt about that. But then also from the Flavor 2 study, we learned about the planning capabilities that we have with using QFR. It may be very relevant to highlight is the guidance that we learned in the Flavor 2 for optimization using QFR also resulted in similar results to the IRUS technology. So these three steps all together, the QFR in my mind came out of that symposium no more as a diagnostic tool, but as a DPO tool, which means diagnostic planning and optimization. And I think you may extend the diagnostic and the planning to other tools like CTA analysis that we also discussed at the symposium. So the session was very comprehensive in the sense that we did not just talk about one solution in terms of just doing the right diagnostic, but we integrated the tool to be used in different phases during the procedure. And I think we shouldn't refer anymore to this technology as a pure diagnostic tool. It is a true DPO tool.
Yeah, so we should really remember that DPO, and also our marketing people should also embrace that and make some nice stories out of that, thanks to your creation here of the words DPO. And I think these are well received, and that is also what basically QFR stands for. And yeah, you've also seen, and you are also doing now your own analysis with the version 3.1, where we are continuous automating and simplifying and getting better accuracy time and again. But also, again, what we emphasize and what we see also in different studies and in daily practice, image acquisition is key. We have an acquisition protocol where we say you need to acquire these and these views at least 25 degrees apart. Make sure that you have no overlap. There's an issue, and also a good contrast injection. It is not difficult, but you have to pay a little bit more attention maybe than what you usually do. Is that also how you understand that?
Let me tell you. So we got the 3.1 version installed already a few weeks back. We have been processing already, more than 50 cases by now. And the idea was to get our hands on and see how user-friendly, and of course, make sure again the diagnostic capabilities of the technology are still there. So again, just rechecking that the newest version still delivers what the older versions did. And to our surprise, Hans, this version is the best you guys have created because it's very fast, it's very user-friendly. I mean, it's 3 clicks. I heard somebody saying 5 clicks, but I didn't find the 5 clicks. It's only
No.
3 clicks.
3 clicks.
And then it really takes no time. And the user interface is very appealing and friendly, but more than appealing and friendly, I would say very informative. Because as I mentioned, you have the diagnostic part, but you also have the planning part in the actual same window. And then you can switch back and forth to inform your stent size, your length, your diameter. Great technology, the 3.1 version. My only complaint is why it took you more than 10 years to do that. So it's just surprising how you guys are the same people. But of course, I guess you have better, engineering tools, programming tools, and software tools to do this in a better way. But I just, could not help myself asking to me, but also to you now, why did it take so long? Because this is really a tool that is going to be very practical and very efficient in terms of the time that it takes to perform this analysis in the cath lab. I think this is going to be a breakthrough for the adoption of the technology. So you mentioned something about the quality, and I want to refer to one presentation at the PCR to answer the quality part that you were bringing up. Of course, we know, like anything in medicine, if we start with the wrong acquisition, with the poor image quality, and that image quality is going to affect our decisions based on that, of course, the outcomes of the patients cannot expect to be any good. So there was this presentation by the favored 3 European group. I think our colleagues from Denmark came up with a sub-study. I think they call it repeat QFR.
Yeah.
And that study actually highlighted this aspect of the image quality and how the image quality might have affected the outcomes in the favored 3 study. And they did very nicely show that. And what is very surprising, and I hope everyone has enough curiosity to go back and check the Kaplan-Meier they presented. So if your angiographic image quality is poor, it means that you are informing your decisions based on the wrong data. And the patient outcomes in this analysis I'm referring to is also the poorest. On the contrary, if your image quality is great, and your decisions, of course, are very well informed because the image quality is great, then the outcomes of the patients are way better than the poor quality group patient. So it is very important and frustrating as well, frustrating to learn that despite so many decades doing X-ray coronary angiography, we're still struggling to really collect a proper image quality, even in the best setup, which is within the trials, right? When you are intentionally really focusing on image quality to deliver the best images for the QFR analysis, despite that, you still have these issues. So I love the study because I don't think we have ever quantified the impact of our poor doing in the cath lab in terms of not collecting good image quality and how we are affecting our own clinical decisions and the patient outcomes. So I hope that that study and that Kaplan-Meier really gets to the head of everyone practicing interventional cardiologists, because it has nothing to do with QFR in my view. It has to do with, if we do poor job obtaining the information, our decisions cannot be any better. They are going to be poor. And the consequences are to the patient. They are not doing well in the follow-up. So I hope Medis and other channels do enough to really spread the study results And I hope that we get the opportunity to have a large forum as well to discuss that at some point.
Yeah, well, that is an excellent point. And of course, this clearly showed in this particular study, the repeat QFR, the impact if your quality is, if your acquisition protocol is not followed properly, you have poor image quality, just like you said it. And it only, I mentioned this also earlier this afternoon with Natalia from Belgrade, that it's also our mission, must be our mission to not only provide proper image analysis, but also emphasize to the interventional cardiology users, make sure that you follow the guidelines. And if you do that and you get proper image quality, it doesn't need to be excellent, but just good enough image quality, then also you get very good coronary physiology results.
You said that it's now your mission to educate us again on proper imaging acquisition. Let me tell you, every time I get the question, are there any specific requirements for QFR analysis? My answer is loud and clear, no. Proper standard of care, high quality coronary angiography is the only thing you need to do, because proper image quality means two views. Proper image quality means proper field contrast, proper high image quality in terms of avoiding overlapping or shortening and all that. So that should be taught during the training. It shouldn't be anyone's mission. It should be trained. All people should be educated and trained on that. And so in my view, the people should think of just learning how to do a proper angiography. And it's embarrassing to admit that, and again, as director of a core lab, we get this a lot, unfortunately. And then you get to talk to colleagues and you just have to confront them with their image quality. And there is no doubt that some of them feel embarrassed to admit that, of course, they didn't do a proper job. So again, image quality is key, but it shouldn't be thought 10 years after you are in practice. It should be thought from day one, right?
Yeah. Now, I don't want to come back to your question, why did it take 10 years? Of course, we have learned a lot during those 10 years and further optimized. But one major development during that 10 years is also the deep learning. Automation by example. So we have collected a lot of data, annotated the data, and by using deep learning techniques, you can teach the software how to process a particular new study. So that also has made a significant difference, and that is why it's basically what we always do, a combination of the traditional image processing approach, like the filtering techniques and so on that you learn at school, at the university, but also this new deep learning approaches where you need a lot of annotated data of high quality, and meaning that the annotation should be of high quality, and then we can learn the deep learning technique process to come up with those automated approaches. So that is why it took 10 years, and I don't hope that it will take another 10 years to make the next major step, because I think we are, as you mentioned, I appreciate your comments on the quality, and we keep on innovating, pushing the standard, and making sure that this will be used in daily clinical practice. And with that, I think it was a very pleasant interview. I thank you so much also for being an excellent moderator. I mean, it was a full house at the meeting. People in the symposium, people were standing in the corridor to get in, but they have to wait until next year. In the meantime, they can also follow this interview and then also learn from summaries of what was presented there.
Thanks for having me, Hans.
Thank you also so much, Hector.